you. And thank you everyone for joining me for an update in chemotherapy and ocular adverse events. I'm the lead optometrist at the Beth Israel Deaconess Medical Center, Longwood Eye Clinic, which you may have heard is partnering with Dana-Farber in coming years, months, years. So this is a really useful topic for us. I want you to just take a second to grab out your cell phones and do this quick survey. We'd like to do a pre-assessment of just your knowledge of chemotherapy, but also your comfort level of chemotherapy and your interest. And then just to note, I have been a paid consultant for AbbVie. So Brave New World. Oncology has evolved. In recent years, there have been large shifts from chemotherapy to what is called targeted therapies and how oncology patients are being managed. New drugs like immune checkpoint inhibitors, monoclonal antibodies, and antibody drug conjugates have become notable for treatment successes as well as notorious for ocular adverse events. And the medical oncologist and the medical optometrist are really a match made in heaven. Given post-pandemic demand for ophthalmologists, having an optometrist care for chemotherapy patients can expedite treatment by weeks or even months. Optometrists are able to recognize adverse events as well as co-manage these patients with oncology teams. And this is actually a good segue for educating our colleagues about our profession. Just as there are different types of oncologists, there are also different types of optometrists. So we all remember what cancer is, where normal cells turn into abnormal cells multiply, and then that turns into malignancy. But tonight, this course will review a very brief history of cancer treatments and newer therapies, such as monoclonal antibodies and immune checkpoint inhibitors and their effects on the eye, specific protocols for increasingly common antibody drug conjugates, or ADCs, such as Elahere or Tivdak, which are known to have ocular adverse events, some ocular adverse events of other targeted therapies, for example, BRAF, FGFR, MEK, and TK inhibitors, and some clinical cases that were co-managed at BIDMC Longwood Medical Eye Clinic with Beth Israel Deaconess Oncology Service. So the emperor of all maladies, the king of terrors. This was an inscription written on the frontispiece of a 19th century textbook on cancer, and is the namesake for a biography of cancer by Siddhartha Mukherjee. Cancer, or carcinos, was named by Hippocrates for the feeder blood vessels it can resemble. Until the 20th century, most doctors thought cancer treatment was all but futile. In treating of cancer, we shall remark that little or no confidence should be placed in remedies. This is taken from a dictionary of practical surgery in 1836. Sidney Farber caused a paradigm shift when he realized that lymphoma fed on folate. He cured a child with lymphoma named Einar Gustafsson from New Sweden, Maine, with a folate antagonist called aminopterin. Sidney Farber, you may know, was a pathologist working in the basement of Children's Hospital Boston in the 1940s. And the Jimmy Fund was born of a collaboration between Sidney Farber and Mary Lasker, a Manhattan socialite, to raise awareness and funding for what had previously been thought to be a lost cause. The child who was sure to die lived to meet the Boston Braves, and this was broadcast on radio in 1948. He was called Jimmy because Dr. Farber could not remember his name. And Einar was the figurehead for a movement that started in the 50s and continues today. Einar ultimately lived into old age. So a folate antagonist, the aminopterin, was the treatment that saved Einar Gustafsson. This is an immunoderivative of folic acid. Folic acid plays a key role in the proliferation of cancer cells in the leukemia. And realizing this, Dr. Farber attempted to use a folate antagonist. Aminopterin blocks the function of folic acid in patients with leukemia. In the 1950s, aminopterin was eclipsed by methotrexate. This is an anti-metabolite pyrimidine antagonist, or a DMARD, like Plaquenil, that interferes with DNA synthesis. It's like cytarabine or 5-FU, you may recognize from pterygium surgery or trabeculectomy. But methotrexate is less potent and less toxic. Methotrexate slows the growth of cancer cells and suppresses the immune system. Ocular adverse events of methotrexate include periorbital edema, blurred vision, photophobia, conjunctivitis, blepharitis, but these are nothing compared to the skull deformities that are caused by aminopterin on the left and methotrexate on the right. In the 1960s, there was the development of anthracyclines. So these are called intercalating agents, which insert themselves into the DNA helix and prevent transcription and replication. Anthracyclines are actually antibiotics that are derived from Streptomyces bacteria that cause DNA damage in cancer cells. So you may have heard of daunorubicin, doxorubicin, or Doxil, which is called the red devil, and epirubicin. These are all anthracyclines. Ocular adverse events include alopecia, so patients get lash loss just like they lose hair, and that can cause exposure keratopathy, dry eye, conjunctivitis, but this is nothing compared to the systemic adverse events, cardiotoxicity that these cause. Another class is this, DNA reactive agent, so alkylating agents, and the first of which was this cyclophosphamide, which was a chemotherapy of the 60s. This is a purine antagonist and actually a nitrogen mustard derivative. It's similar to chlorambucil, and the alkylating agents form crosslinks between adjacent nucleotides to suppress tumor growth by abnormal base pairing, DNA strand breaks, and stimulating DNA's cross-linking. This is how these drugs stop cell division. Ocular adverse events include blurred vision, epiphora, blepharoconjunctivitis, K-SICA, and pinpoint hemorrhages. More alkylating agents. So you may have heard of cisplatin or carboplatin. This was developed in the 70s. These are called platinum analogs. And these also react with DNA. So there'll be DNA strand breaks, or they will insert themselves into DNA, and that will cause the tumors, that'll cause cell death. On average, patients treated with platinum analogs vomit 12 times a day. And they do cause ocular adverse events as well. Retrobulbar neuritis, optic neuritis, macular pigmentary changes, cortical blindness, hemianopsia, photopsia, ocular pain, cystoid macular edema, ischemic retinopathy have all been reported with platinum analogs. And treatment includes corticosteroids, topical and systemic. But these ocular adverse events tend not to be reversible. Another class of alkylating agents include the plant alkaloids, of which vincristine is one. This vinca alkaloid is derived from a substance found in the Madagascar periwinkle. So like the vinca that we see just at this time of year in Boston, it's in the same family, but this actually has a poison. This plant has a poison that thwarts the ability of the cell to divide. It's what's called an antimitotic or an antimicrotubule alkaloid. It stops the cancer cells from separating into two new cells. This was found to decrease the number of white cells in the blood, and is an effective treatment for leukemias. So here we have an example of vincristine optic neuropathy in a 9-year-old boy with Burkitt's lymphoma that progressed to light perception OU in a matter of days. So this presenting photograph here on the top is when the child was 20/20 vision, and then the bottom photo is when the optic nerve atrophy you can see is pretty dramatic, but that's when he was light perception. But interestingly, in this case, 3 months, so at the baseline photo here, when the optic nerves look pretty normal, this ganglion cell IPL down on the left, figure A, was very abnormal. And then when he progressed to light perception vision, that's when his ganglion cell IPL progressed to figure B. So the thinking is that maybe ganglion cell IPL could detect the vincristine optic neuropathy, earlier. Another plant alkaloid is the class of the taxanes. You may have heard of paclitaxel, docetaxel. These emerged as best-selling anti-cancer drugs in the 90s. These stabilize microtubules and promote mitotic arrest. Originally, these were isolated from the Pacific yew tree, And ocular adverse events include conjunctivitis, subclass heme floaters, dry eye, blepharitis, glaucoma, TIA, optic neuropathy, macular edema. But fortunately, these are reversible with discontinuation. So alkylating agents, in summary, so the platinum drugs bind to nuclear DNA of the cancer cells that disrupt the DNA replication. Vincristine prevents microtubule aggregation. Paclitaxel prevents microtubule disaggregation. All 4 anti-tumor agents alter the function of mitochondria. All 4 cause activation of immune cells, in effect likely contributing to tumor cell degradation. You may have heard of CHOP therapy, and this is a combination of multiple of these drugs: cyclophosphamide, the nitrogen mustard derivative, vincristine, the plant alkaloid, doxorubicin, the red devil, and prednisolone. It's a lot. So, but you can't see the forest for the trees. So it's important to understand where we've come from to understand where we are now. So the last 30 years have really focused on targeted therapies. Older style chemotherapy has poor specificity, which results in poor therapeutic response, and also these drugs are highly toxic to surrounding tissues. Now, the newer targeted therapies, or even what they call non-chemotherapies, select and kill tumor cells with less harm to healthy tissues. These include monoclonal antibodies, bispecific antibodies, and antibody drug conjugates, where there's an integration of the antigen specificity of a monoclonal antibody with a powerful drug. So this monoclonal antibody is attached to drug that delivers the drug, and then it delivers the drug directly to the cancer tissue. Monoclonal antibodies, you may remember, are immune system proteins made by cloning a specific white blood cell. And these bind their target growth factor receptors to block tumor growth. So, bevacizumab or Avastin was used in cancer before it was used in eyes. And then you may have also heard of rituximab. Bispecific antibodies is its own class, although not as many members of this class. It's a combination of 2 different antibodies that can bind to a pair of contrasting targets. And then most importantly, I think, is the antibody drug conjugate. So this consists of a monoclonal antibody, a chemical linker, and an anti-neoplasm or cytotoxic payload. So cytotoxic payload is the drug. So that's the drug that you want to get to the cancer. The monoclonal antibody takes the drug directly to the cancer tissue and attacks it. So this includes amatoxins, microtubule targeting agents, anthracyclines, we already mentioned, the red devil Doxil, maytansinoids, and auristatins. But in this class are 2 relevant drugs to us, Tivdak and Elahere. Monoclonal antibodies are man-made proteins that act like human antibodies in the immune system. To recall, these white blood cells are called plasma cells that produce antibodies during the course of infection. And the antibodies are the Y-shaped proteins. The base, or the vertical leg of the Y, helps it communicate with other components of the immune system, and the tip of the antibody, the both arms, bind to foreign invaders. There are 4 ways they can be made and are named accordingly. Murine, so these are made from mouse proteins, and the names of the treatments end in OMAB. Chimeric, these proteins are combination mouse and part human. These end in Zumab. Humanized, these are made from small parts of mouse proteins attached to human proteins, and these end in Zumab. And human, these are fully human proteins, and the names of these treatments end in OMAB. And fun fact, actually, Metro West Boston has factories of mice in which these monoclonal antibodies are being produced. So bevacizumab, our favorite monoclonal antibody, our very own Avastin, this blocks VEGF. It's an anti-angiogenic therapy, we all know. But the reason this is so important in oncology is because tumors cannot grow without their feeder vessels. So it starves the tumor. Bevacizumab is used in combination with other chemo drugs to boost their effects. You may have heard of Herceptin for breast cancer that targets HER2 positive. And rituximab is used in lymphoma and leukemia, and it's also even used in rheumatoid arthritis. So monoclonal antibodies trigger the immune system to attack and kill cancer cells. Some monoclonal antibodies attach themselves to cancer cells to make it easier for the cells of the immune system to find the cancer. They like attach to the cancer and they're like, hey, come get me. And this process is called antibody-dependent cell-mediated cytotoxicity, or ADCC. Notable monoclonal antibody is this Dupixent, dupilumab. This is used to treat severe atopic dermatitis because it blocks the type 2 immune response. But recently they found that it may downregulate the programmed cell death pathway, PD-1, and enhance immunotherapy for cancer. So I mention this because we may be seeing this in combination with other chemotherapies, and it has its own entity, DAOSD, dupilumab associated ocular surface disease, which includes conjunctivitis, keratitis, blepharitis, dry eye, punctal stenosis. So just really, severe hyperemia. Prophylaxis protocol is with lubricating eye drops, and then you can treat this as you would with any dry eye, lubricants, corticosteroids, cyclosporin, lifitegrast, or even tacrolimus. So moving on to immune checkpoint inhibitors. So we talked about monoclonal antibodies. Immune checkpoint inhibitors are a specific subset of monoclonal antibodies. Immune checkpoints are a normal part of the immune system that prevent an overly strong immune response. And immune checkpoint inhibitors are a kind of monoclonal antibody that block proteins CTLA4 and PD-1 on cancer cells and allow the immune system to better attack the cancer. So the patient's own T cells are better able to recognize and destroy the cancer cells. So this CTLA4 is, short for cytotoxic T lymphocyte-associated protein 4. PD-1 is programmed cell death protein 1. So these are important in oncology right now. But what you need to know about immune checkpoint inhibitors is that this results in a general upregulation of the immune system. By upregulating the immune system to attack cancer cells, immune checkpoint inhibitors can also cause an inflammatory reaction in healthy cells, termed immune-related adverse events. So here's a short list of some CPIs, ICIs, immune checkpoint inhibitors. I think Keytruda is the one that I recognize, but but then when you see these that end in Zumab, Umab, now you know, okay, this is there are so many immune checkpoint inhibitors on the market, it's actually pretty likely that it's an immune checkpoint inhibitor. So, Google it and see if it is, because then guess what? It causes uveitis. So immune checkpoint inhibitors can cause blepharitis, conjunctivitis, keratitis, but really most importantly, uveitis, anterior or posterior, vitritis, retinitis, cranial neuritis, and optic neuritis, orbital myositis. So all kinds of inflammation in the eye. And, treatment of anterior segment inflammation includes topical corticosteroid drops, and the posterior segment inflammation would be treated with systemic steroids. If systemic steroids are used, the drug should be held per ASCO guidelines. That's the American Society of Cancer Oncologists, I think. And then before attributing the ocular condition to drug toxicity, other inflammatory infectious etiologies should be ruled out. Here's the problem with immune checkpoint inhibitors, right? So do you really know that this is, inflammatory cell in the anterior chamber? Or is it, could it be a pseudohypopian, like you see, like an infiltration of the anterior chamber, which you see in leukemia or lymphoma? So a purist would say that the patient should be referred to a uveitis specialist. I don't think you have a whole lot of them in northern Maine, where I'm from, Presque Isle, but, just, I guess, do your best. And then Massainer, or there's this Mercy, MERSI, I can't remember what it stands for, but they are in Waltham, Massachusetts, and they are fabulous. It's easy to get the patients in, and they're happy to, this is the problem for me, is it's hard for me to know, is this the leukemia or is it the immune checkpoint inhibitor? It's probably the immune checkpoint inhibitor, but I'm an optometrist. I'm happy to refer this out. And then any case of orbital or optic nerve involvement should also have MRI. So this is a case of optic neuritis in the setting of pembrolizumab, the Keytruda. This was a poster presented at AAO New Orleans in 2023 by my colleague, Yu Su. So pembrolizumab inhibits the programmed cell death 1 PD-1 pathway, resulting in an enhanced immune response to fight many types of cancer. Only less than 1% of patients on pembrolizumab develop ocular complications, but they can be significant when they do occur. This is a case of a 57-year-old female that presented with decreased vision in the right eye, pressure and pain in both eyes for 3 weeks. Medical history was positive for triple-negative breast cancer, status post-carboplatin. Remember, that's a platinum drug. Paclitaxel, that's the taxane, right, from the yew tree, and pembrolizumab, so that's our monoclonal antibody, our immune checkpoint inhibitor. The vision was 20/50 in the right eye, 20/20 in the left eye, and she had granulomatous KP, optic nerve edema, as you can see in the photo to the right, peripapillary cotton wool spots and hemorrhages. She had a lumbar puncture that was normal, and this patient was seen by neuro-ophthalmology, and she was initiated on 60 prednisone with a 10 milligram taper weekly. The pembrolizumab was held, and then there was resolution in 6 months. So we've talked about monoclonal antibodies. We've talked about this subset of immune checkpoint inhibitors. Now here we are with this antibody drug conjugate. Okay, so this is a monoclonal antibody with a chemical linker that attaches itself to an anti-neoplasm or cytotoxic payload, the payload drug. Now the payload drug is the toxic agent that inhibits mitosis. So that is to say, these are the drugs that stop cancer in its tracks. These are very toxic drugs, which is why ADCs are so clever in targeting malignancy, because this patient is spared many systemic adverse events. We know about monoclonal antibodies, but here are the chemical triggers, so the chemical linkers. These control the release of the payloads. Some are photoresponsive, the release with UV. Some are acid cleavable because they utilize the difference between the tumor tissue and the plasma to selectively release payloads into the tumor tissues. And there are many others. If a trigger causes a linker to release a payload in normal tissue, there will be off-target toxicity. So, and then we've got the monoclonal antibody for the linker, and then the cytotoxic payload. So there's a class of these cytotoxic payloads that we've sort of touched on, this microtubule targeting agent. So remember, microtubules are major components of the cytoskeleton in eukaryotic cells. They're involved in mitosis, movement, and cell shape. And so for these drugs, you can have microtubule inhibitors or stabilizers. So what that means is, imagine a magnet, right? So if you have a magnet that pulls together very, very tightly, then you can't separate the magnet. So that's a microtubule stabilizer, right? Something that's stuck together. And then there's a microtubule inhibitor, something that's like the polar opposite of the magnet, where you can't push it together. That's an inhibitor. And both of these result in cell death. Some examples of microtubule targeting agents include this MMAE, MMAF, stands for monomethyl auristatin E and F. This is a synthetic anti-neoplastic agent. And then there's DM1 or DM4. This is a maytansinoid, so it's from a tree. Again, lots of plants in this field. And epothalones, these are from Myxobacterium and are antifungal as well as microtubule targeting agents. There are also DNA reactive payloads. So amatoxins are from the death cap mushroom. So you'd never eat a death cap mushroom and live, but if you can stick a little bit of death cap mushroom on the end of a monoclonal antibody that just goes right to a tumor, then that's like a really good situation. So these trigger the formation of free oxygen radicals, and this damages the strands of DNA within the cancer cell. So it's delivered directly to the cancer cell with the antibody drug conjugate. And then more DNA reactive payloads include calyciamycins, which are anti-tumor antibiotics that were found in soil in Texas from bacteria that was found there in the dirt. Camptothecin, which was isolated from the bark and stem of a tree used in traditional Chinese medicine. So there are all these kinds of very toxic drugs, and they are linked with the linker to the monoclonal antibody. Here is just a short list of some. So Adcentrist, for example, is an ADC made up of an antibody that targets the CD30 antigen, and it's attached to MMAE. And it's used to treat Hodgkin's lymphoma. There's Kadcyla, which is targets the HER2 protein, and it's attached to DM1, used to treat breast cancer. And there are several others, and there are so many in the pipeline. This is not the last time you will hear about antibody drug conjugates. But what makes antibody drug conjugates so special is that they cause a lot of ocular side effects. So they do cause dry eye, blepharitis, uveitis, but they cause this special microcyst-like epithelial change that they call MECs, MECs, that are similar to microcystic edema, like what you would see in like a contact lens overwear patient, like these tiny bubbles in the peripheral cornea. But they're not just a few of them, they're florid. And there's also, limbal stem cell deficiency. I have not seen this, but that can occur, and it has been reported in ADCs as well. So antibody drug conjugates. This is the characteristic epithelial keratopathy that is associated with the ADCs, this microcyst-like epithelial change. The peripheral cysts, like I said, these little bubbles in the periphery, they do not stain initially, and they move centrally and anteriorly, so they eventually cause fluorescein staining, sort of like when you see a PBK patient, how the bubbles start posteriorly, they move forward, and then when they erupt at the surface, that's when they stain. Microcyst-like epithelial changes have been associated with changes in corneal epithelial thickness profile and corneal topography, which may prevent with blurred vision or refractive shifts. Oncologists are tasked with co-managing these adverse events with eye care professionals, and if ocular toxicity occurs, eye care professionals must identify the grade and communicate with the oncologist so that treatment can be held or the dose modified, either delayed or reduced. So the job of the optometrist is to differentiate between a transient refractive shift and a true anatomical change. So actually I saw 3 patients today that were on antibody drug conjugates. 2 of them had no ocular side effects, they were fine. And the third one didn't have an ocular side effect either, but she was so symptomatic for blur that, of course, her oncologist thought that she was having an ocular side effect, but she just was, her prescription was just, she was complaining of an increased reliance on a prescription that was given to her from vision work. So this has absolutely nothing to do with the drug that she's been prescribed, but patients don't know that and oncologists don't know that. So that's why this is why it makes so much sense for optometrists to be involved here. Not only because we look at the cornea, but most importantly, we do a refraction. I feel like that is half of, the process of figuring out, is this really an anatomical change, or is this just a change in refraction? Does it mean really this is not a big deal? So I'm just going to list a few of these ADCs that are relevant to us. There's Blenrep, which was a treatment for multiple myeloma that's now been discontinued. Tivdak is now FDA approved for recurrent or metastatic cervical cancer. And there's a black box warning for ocular adverse events just because of these things that I just described to you, these microcyst-like epithelial changes and other adverse events. And then Elahere, which is platinum, it treats platinum-resistant ovarian cancer. And this has a black box warning for ocular adverse events. For this microcyst-like epithelial change, actually Tivdak is more conjunctival, but anyway, there are ADCs that cause ocular adverse events, and this is why optometrists are really helpful to be able to sort through what's going on with the cornea. So as I mentioned, the microcyst-like epithelial changes cause refractive topographic changes as well as slit lamp finding. So you can get increased astigmatism, and you can get a hyperopic shift due to the peripheral stromal edema. So it's interesting. So actually imagine an orthokeratology fit, right? Where you have, peripheral. So this actually, you can get these circinate, like little opacities all the way through the epithelium in a circle, peripheral cornea. And then the topography looks like this. You'll have a circle of steepening and then a flattening in the center. So that's almost an ortho-K fit. If you look at figure C over to the right, this is actually from a patient who's on Blenrep, and you can see this actually has a little bit of that like ortho-K look to it. But most important for us to remember is that the treatment of microcyst-like epithelial changes is dose modification. So, as optometrists, we are tempted to start steroid eye drops, but these have really not been shown to help with microcyst-like epithelial changes from ADCs. Steroid eye drops are only used to prevent epithelial absorption of the payload drug. So they use it prophylactically, but there really is no reason to increase the steroid when you see the microcyst-like epithelial changes. Believe me, I've tried, and I didn't have to, and I didn't need to, and it didn't do anything. So it's really just the dose modification. When you talk to the oncologist, and they figure out what dose they're going to give to the patient. Now, this is pretty stressful, right? I mean, like, you're talking about somebody's, cancer treatment. But what my understanding is that when you're seeing a lot of corneal changes, that actually is a reflection of how much of the drug is in the patient's bloodstream. So if you are seeing a lot of keratitis, reducing the drug is not going to harm the patient's treatment course. It's just going to make it so that they tolerate it a little bit better. And I've heard it said that each patient is a study in their own treatment, because you give them what you think, or the oncologist gives them what they think is the correct treatment, dosage for them, but then they change it over the course of their disease to sort of strike this balance between adverse events and having an effect. So the microcyst-like epithelial changes resolve with discontinuation or dose modification of the ADC, and this is why communication with oncology is paramount. So just to go over this again, so these microcyst-like epithelial changes progress from the peripheral cornea to the central cornea. So initially, the vision might not be that bad, but then a few weeks later, as it moves centrally, the vision will really be affected. And they also progress anteriorly to go from being like microcyst-like to actual SBK. So this is why it's so important to stress preservative-free artificial tears, and I stress ointment too. So the current standard for grading and reporting adverse events in cancer clinical trials is clinician grading using the common terminology in cancer adverse events grading scale, or the CTCAE, that was developed by the National Institute of Health, the National Cancer Institute, and has been evolving since the 1980s. But it didn't really drill down about the keratitis until the more recent iterations of this CTCAE. This was developed with cancer hospitals, including Memorial Sloan Kettering in New York, and they have a pretty succinct description of how this keratitis can be graded. So grade 1 is asymptomatic, clinical or diagnostic observations only, intervention is not indicated. Grade 2, symptomatic, moderate decrease in visual acuity, so best corrected vision 20/40, or say the patient has AMD and they came in at 20/30 to start off with, so then you're 20/40, 50, 60, so the 20/70, and then so if they're 20/70, or if they're better than 20/70, then that's less than 3 lines of decreased vision from baseline. Grade 3 would be symptomatic with a marked decrease in visual acuity, so worse than 20/40, but up to 2200. Grade 3 would include corneal ulcer, and then grade 4 includes perforation, which I've not seen, and best corrected visual acuity of 2200 or worse in the affected eye. So Blenrep has been discontinued, but it's so important because there have been so many reports of this keratopathy. So belantamab mafodotin is an ADC that was used in the treatment for multiple myeloma. And it had this, microcyst-like epithelial change, but it was withdrawn from market last year because of thrombocytopenia. But we learned a lot from Blenrep. So what the thinking is that these drug particles of the ADC are thought to reach the cornea through the tear film. The drug is internalized by the corneal epithelium through the process of macropinocytosis, where the cell engulfs the drug from the tear film, and it's not unlike in phagocytosis. So if you look at this figure, bottom left, you can see how the tear film is like the purple, and then it actually goes into the epithelium and it becomes like phagocytosed. So the damaged corneal epithelium then, starts peripherally but migrates centrally and anteriorly. Blenrep, because it was studied in, these cancer centers, I don't have a confocal microscopy, but they have this. And so they found hyperreflective deposits that were detected in the deeper layers of the peripheral cornea, even before the clinical signs were apparent. And they called this the bunch of grapes. But, most importantly, 63% of study participants developed corneal events. 9% were severe, stromal edema, SPK, microcysts, opacities. But, just like the other ADCs, the median time to onset was 23 days. So if you're getting this drug every 3 weeks is, seems typical, then after the second infusion, that's when you start to notice the vision change. But the good news is the median time to resolution after treatment exposure was, about 1 or 2 months. So after they stopped, then the vision did go back to baseline. In the presence of grade 2 to 4 corneal events, the dose should be delayed until there's an improvement to grade 1. And at grade 4, permanent treatment discontinuation be considered, but not necessarily. You can always reduce the dose too and reintroduce. So Blenrep, we learned a lot from Blenrep, but it was withdrawn. Now, Elahere is a treatment for patients with folate receptor alpha positive ovarian cancer, fallopian tube cancer, or primary peritoneal cancer, and who are not responding to platinum-based therapies. Now, we know carboplatin, right? So platinum-resistant ovarian cancers. That's what this drug is for. There's only a 5-year survival rate of 30 to 50% for these patients. These patients are ill, and the FDA gave accelerated approval late in 2022 because of this. The full approval was only given in March 2024. And mirvetuximab soravtansine GynX, it targets folate receptor alpha, and it has a folate receptor binding antibody, a cleavable linker, and it has the maytansinoid DM4. So MIRV versus chemotherapy had a 33% improvement in overall survival, but we're still talking only 16 months versus 12.7. I mean, these patients are sick. And like I said, they get their infusions about every 3 weeks, and they need their eye exams every 6 weeks for the first 8 cycles, and more frequently with ocular adverse events. So you can get blurred vision, change in refraction, this microcyst-like epithelial change, dry eye, uveitis, photophobia, eye pain, and cataract. So they have a protocol. The eye drop protocol is steroid 6 times daily, starting the day before treatment and for 3 days after the infusion. And then you drop to QID for 4 more days. The steroid, though, is thought to thin the corneal epithelium and promote desquamation of the MIRV-induced corneal microcyst-like epithelial changes from the ocular surface. It's not used for its anti-inflammatory properties. The nurses in oncology give out a starter kit with information as well. I feel like the more the patients hear the drop schedule, the better. It's pretty stressful. I mean, it's hard to, 6 times daily. I've had people cry when I told them that when I asked them to do drops 6 times daily. These are fragile patients. So I try to be pretty gentle and do your best, and I give them written materials because starting, 6 times daily, starting the day before the Elahere for 3 days thereafter, and then drop to 4 times daily on day 4 after treatment, continue 4 times a day for 4 more days. It's pretty confusing. I've argued with the company many times. It should be QID for a week, but this was what was in their trial. So, I mean, I have to stick with what they actually, what was studied. So here we have the ocular assessment form. Shoot, I meant to take that out. So electronic or paper is fine. So you email this or fax it to oncology, and this reflects the CTCAE that we talked about, right? The common terminology in cancer adverse events. So if you look down here, so it has non-confluent superficial keratitis, confluent SPK, 3-line or more loss in best corrected visual acuity. So this form reflects the CTCAE. And then you have best corrected distance acuity of 2200 or worse, or stromal opacity. So these are all, and then uveitis. So you try to characterize it and you track the acuity. Microcyst-like epithelial changes can be severe, but one of the take-home messages here I want for you today is that the microcyst-like epithelial changes are not stromal. And I've made the mistake because they can be so significant that it really looks like a stromal opacity, but it's not. They are at the level of the epithelium. And because if you do, check off that you're having stromal opacity, then it actually bumps the grade up to an extra level. So just be aware of that. The eye exam protocol includes a comprehensive eye exam at baseline. We perform slit lamp photos often, but this is not required. At every 6-week visit, I do vision, refraction. I evaluate the cornea without fluorescein first, just to make sure, that I'm seeing what I want to see. And then with the fluorescein after, to evaluate for staining. Eye pressure because they're on steroids. And then if they have worsening of vision, I do dilate. I get a macular OCT once in a while. And that's all normal. It's all just corneal. I just see corneal. Okay, so here's a case study. MH, 56-year-old Black female with recurrent stage 3C ovarian cancer, Mullerian carcinoma. Status post excision of pelvic tumor, hysterectomy, oophorectomy, colon resection, omentectomy, ablation of diaphragm tumor. And you see she's done carboplatin, platinum drug, paclitaxel, taxane, and then these other drugs too, in addition to bevacizumab. She was so sick when she first came to me. She was an inpatient when she first came to me. Best corrected vision, though, was 2015 ODOS. I asked her to discontinue her contact lenses, and I prescribed her the steroid and told her to take the artificial tears. I communicated the findings with the oncologist prior to starting the Elahere. And, I actually just had a conversation with the cornea specialist I work with this week about language here, right? So, I think the older language would be clear the patient for Elahere, just like we used to do, clear the patient for Plaquenil. And, there's a lot of liability. The cornea specialist I work with was pretty adamant that I should not be saying those words. So I communicate my findings. And status post Elahere ×3, she did complain of blurred vision. Her entering acuities were 20/60 and 20/40, but her vision improved. I refracted her to 20/20 and 20/25 with a hyperopic shift. So I just filled out the form, and there was no dose reduction that was applied to this patient because she was still like a very she was grade 2. And then status post Elahere ×4, she comes in and her vision is 2300 and 2400 best corrected, moderate SPK with what looked like pigmented microcyst-like epithelial changes in both eyes. She was not driving, but I told her not to drive. And then, I called this grade 3 keratopathy, but actually in retrospect, I think it's grade 4 because her vision was so poor. The Elahere was held. And then 3 weeks later, the vision in the cornea had actually improved to 20/20 and 20/30. And the oncologists had termed this an amazing clinical response to treatment. We'll talk about this when we look at her CA-125 numbers on the next slide. So when they resumed the Elahere, they reduced the dose by 17% for Elahere cycles 5 and 6. And then there was recurrence of keratitis. So they reduced it again to 33% with a milder recurrence. And then she resumed a 25% reduction for Elahere 11 and 12. So this is, 12 times 3. That's a lot of weeks. That's 36. And she took a vacation in the middle. She's been on this drug for almost a year now. And her vision is 20/20 minus. She still has a little bit of corneal changes. So this CA-125 is a cancer antigen 125 that your patients will talk about. It's monitored in ovarian, endometrial, peritoneal, fallopian tube cancer, and it helps to evaluate for cancer recurrence. So I'm sorry that this is sort of backwards. I just copied it from the chart, but you can see here for this patient down at the bottom, June of 2023, she was in the 600s, her CA-125. And you see at her second infusion of mirvetuximab, Elahere, that's half of what it was. She went all the way down to in the 40s, 25 at one point. And then we held the Elahere at this point. She's here at cycle 10, so she's creeping back up again. But, the drug is kind of amazing. And this is just such an interesting curiosity. This patient had almost an ortho K effect of her peripheral microcyst-like epithelial changes. After her 6th infusion, her vision improved so much that she walked in. She's like, "You're not going to believe it. I can drive without glasses for the first time in my life. I almost died." And then I checked her vision, and her uncorrected vision was 20/25. I mean, this woman is like -5-ish, normally, but she could see without glasses. And I told her to use extreme care and, really try not to drive if she can avoid it. But she's still she's from her baseline when she was so ill, she had made just such an amazing response. She's so with it. She's working. She's back at home. She's not living with her parents anymore. And so this 4 diopter hyperopic shift resulted in she didn't even need her glasses for a while. There was a 33% dose reduction. And now I just checked her chart this week. She's had 12 infusions of Elahere. She's back to her stable myopia, -450 with SIL, and she has clear corneas. So moving on to Tivdak. So Tivdak is an ADC, an antibody drug conjugate that has a monoclonal antibody directed toward tissue factor and highly expressed in cervical cancer, a protease cleavable linker, and a microtubule disrupting agent, monomethyl auristatin E, MMAE. So interestingly, Genmab came together with Seagen to combine technologies. Genmab had the monoclonal antibody and Seagen had the linker, and they were like, let's get together on this one. So tisotumab vedotin is indicated for the treatment of adult patients with recurrent or metastatic cervical cancer with disease progression on or after chemotherapy. So accelerated approval dates to 2021, but it only gained full FDA approval on April 30th of this year. Despite the wide use of pap smears and HPV vaccines, 6% of women will have metastatic disease at the time of diagnosis, and 30% of patients will have recurrence. The 5-year survival rate for these patients who have metastatic disease is less than 20% in the US. And why this is so relevant right now is that, Maine and Rhode Island, the new case rate is around 7 or 8 per 100,000. Whereas in New Hampshire and Massachusetts too, it's like 3 or 4 in 100,000. So your states are actually, have a little bit of a higher incidence of this cervical cancer. Now, Tivdak shows promise in overall survival with a 24% response rate. But, median overall survival is still like 11.5 months with Tivdak versus 9.5 with chemotherapy. But, these are sick women. Like they are, the thing about the FDA is that you start introducing these drugs with the very sick population. And, the hope is that one day the treatment paradigm will shift. So maybe it won't be for the people that have already had metastatic disease. Now that these patients will get the drug. This has a box warning for toxicity. And so there's FDA required eye care involved. There's a baseline anterior segment exam, slit lamp exam, corneal exam, and eye exams every 3 weeks. So before each infusion for 9 cycles. We prescribe brimonidine. I do the prescription, not the oncologist. I think for the steroid and for the brimonidine, they do not know their way around drops, so I'm happy to do it. But the brimonidine is actually required because of its vasoconstrictive effect. So the nurses at the infusion center give 3 drops immediately prior to the infusion. The patient brings them with them to the infusion center. And they get cooling eye pads, and they get prednisolone, 1 drop 10 minutes prior to the infusion. And then they do the prednisolone 3 times a day for 3 days. They also do preservative-free artificial tears 3 times a day for the duration of treatment. But I have to comment here. So this cooling eye pad, right? So the idea behind this and the brimonidine is the vasoconstriction. So the drug doesn't get to the eye if you're vasoconstricting those vessels, right? And, if you think about the hair, people who want to keep their hair during chemotherapy, there's like some kind of cooling thing for the head as well. And I don't know, I haven't had nearly as many Tivdak patients as I have with Elahere. But I've actually started when the Elahere patients have the keratitis and they have to go back on the drug and they're going to go on at a reduced dose. I started telling them that, can you bring a cold pack with you for the infusion suite? It's not part of the, treatment protocol at all for Elahere, but I don't know. I mean, it doesn't do any harm. It might actually do something good, and whatever. It seems like it's pointing in the right direction. So Tivdak patients also get a starter kit with preservative-free tears, and they have a text program, so the patients can get signed up so they can remember to do their drops at certain times. I give my own instructions, but the nurses do too. And ocular adverse events, about half of the patients will have, a conjunctivitis, more commonly, I think, than dry eye, and then blepharitis, chalasia, eyelid edema, corneal ulceration. And, of note, we tell people to discontinue their contact lenses before they start their ADCs. But although the contact lenses are contraindicated with ADC use, bandage contact lenses can be helpful in managing corneal SPK. But I mean, I haven't used it for that. The cornea specialist I work with does. And I did refer a patient to her with an epithelial defect, not with Tivdak, with Elahere. And she used a contact lens for that. So the concern is that the drug absorbs into the contact lens, and that can exacerbate the keratopathy. But this has not been formally studied, so you can just use your clinical judgment. Tivdak materials are very similar to Elahere materials. I personally save a PDF with the patient name, and I modify it at each visit. And then I email the oncologist with the updated form after each visit. So, and you can see here that, of course, we've got the acuity and then the SPK, but there's a large section for conjunctivitis here. So that's probably something that you'll encounter. And I just want to make a nod to a couple other chemotherapies. BRAF mutant melanoma has this treatment called BRAF inhibitors, can cause uveitis and dry eye. And same idea, withhold and then treat the uveitis with steroid. Fibroblast growth factor receptor, FGFR inhibitors, are treatment for colon cancer. And you can get this multifocal, serous retinopathy with this drug, and with the MEK inhibitors, mitogen activated protein kinase inhibitors. So these have their own entity called MECAR, MEK inhibitor associated retinopathy. So you can get yellow-gray retinal elevations. Tyrosine kinase inhibitors. You can get periorbital edema. You can treat this with steroid or even an oral diuretic. And, it's funny, back when I was in optometry school 20 years ago, the only chemotherapy that I really learned about was tamoxifen. This was the only one that was really relevant back then. Selective estrogen receptor modulators that bind to the estrogen receptors, and they would create these retinal deposits. And this is just treated with discontinuation. And then the last one I want to mention is this Velcade. So this is a proteasome inhibitor used in the treatment of multiple myeloma and lymphoma. And it causes these multiple bilateral chalasia. And the effects on the meibomian glands are pretty severe. The thinking is that this might point to a viral etiology for chalasia, which I didn't even know, but apparently herpes, Epstein-Barr, and adenovirus have all been implicated in chalasia. And this may be indirect evidence that there's a virus-related etiology because bortezomib may facilitate viral infections. And then, so if you want to learn more, actually, there's a great continuing ed out of the Sloan Kettering Review Education Group has it. And if you have a patient on a specific drug, look at their website, talk to the drug reps, and seek out the medical science liaisons to have scientific conversations. They're happy to talk to you. And call the oncologist, ask for the form that they need, and email me. Reach out to me at klamoray, at bidmc.harvard.edu. But I'm going to go back to that in 1 second. Okay, so I think that Caroline wants us to do a short survey, and then we'll go back to that slide.
Yeah, I just changed that out, Dr. Lamoureux, because I wanted you to be able to continue all that you had to do and also get Emily on. I will be doing the survey in a follow-up email. So for all of you that need CE from tonight, we ask you to do a really quick 3-question survey, and it will be coming to you in the follow-up email.
Okay, then thank you so much, Caroline. Sorry about that. So just take a quick second for the post-assessment. Everybody scan your phone, post-assessment, update and chemotherapy and ocular adverse events, just to give us a gauge of how you feel about, this topic, and if you have, questions about it, or if you what your comfort level is in, seeing these patients.